So first of all, thank you for being invited to moderate today. Thank you, Alex, and thank you to Mike. As Alex said, my name is Heather Edward. I wasn't a ballerina. I wish I could say that. I was thinking, what do I say? But I have had the honor of serving as a leader in pre-hospital care for 26 years. I've served in 4 services across Canada, started as a PCP, and I worked all the way up to executive leadership. The last position I was with was BC EHS. So part of being in that leadership is I joined leadership because I didn't just want best practice, I wanted innovative practice. And so that sort of altered my career, which has ended me up. Today I'm a researcher through Queen's. A lot of what the people were talking about today is something I'm researching. So this conference isn't about me, it's about what we're gonna do, but I am doing leaders' mental health. And a lot of what we've talked about today is the mental health of the leaders, moral injury, all the stuff that was said today. So basically it brought me to where I am today. Today I'm the CEO of the Saanich Peninsula Hospital and Healthcare Foundation. I realized I couldn't change the system by being a leader in the system. So I wanted to change the system from outside the system. So the organization I'm with, we've raised $100 million to fund the healthcare system. Personally, $23 million in the last few years in a nonprofit organization such as what hopefully this will become. So that was about me. Quickly, hopefully that was enough. So let me introduce the first member of our panel today. Please stand as I introduce you. You deserve to have some recognition here. So Carolyn Kelly-Smith. Carolyn is an FRCPC-trained emergency medical physician. She works full-time clinically at the Royal Columbian Hospital as an emergency physician, trauma team leader, and critical care physician. That's pretty cool. Carolyn has a special interest in pre-hospital medicine, especially in the wilderness and mountain environment. She holds the International Congress on Alpine Rescue, Diploma in Mountain Medicine, and was involved in developing and teaching a Canadian diploma program. That's pretty neat too, Carolyn, wow. She volunteers with Whistler Blackcomb Ski Patrol as an on-hill physician and has worked as the on-site physician for, I don't know how you say this, pronounce this right.
Oh, Mike Weigele.
Mike Weigele Helicopter skiing. She has also worked overseas for the Himalaya Rescue Association in Nepal, at a remote clinic, and done consulting work for a helicopter rescue company on Mount Kilimanjaro. Recently, she deployed to Jamaica as part of the medical aid response to Hurricane Melissa. Carolyn's biggest passion outside of the hospital, is her work with North Shore Rescue here in Vancouver. She is a full member of North Shore Rescue as well. She is a full member of North Shore Rescue as well as a member of their advanced medical provider team. She is also a helicopter rescue technician for the team and recently took over as medical advisory chair. So this session is on the development and impact on interprofessional teams, and it's over to you.
Thank you for the introduction. I don't think I really need to say more. I'm going to talk to you about our North Shore Search and Rescue Advanced Medical Provider Team, as mentioned. I got involved with North Shore Rescue back in 2010 when I was just finishing my residency in emergency medicine. At that time, I was the only physician on the team. There was a couple of advanced care paramedics that helpfully kind of taught me the ropes, a little bit of pre-hospital training and pre-hospital medicine. But we were all kind of winging it, to be honest. I certainly was. And since then, we've kind of come a long way. So I want to just talk to you guys about that process. First, just a little bit of information about search and rescue in BC, because I don't know if everyone's aware of how it works. So search and rescue in BC is completely volunteer driven. There's 78 teams across BC comprised of volunteers that respond to search and rescue calls. It's also a free service. So it doesn't matter how many stupid decisions you make to get yourself where you are, we will still come and get you. And in order to be part of this program, you have to do a 1-year ground search and rescue certification. So this is like a 1-year member and training program followed by a written and practical exam, and then you become a full member of your team. In order to activate us, it's usually a 911 call. And then once the governing body, either police, fire, ambulance, determine that the location of the call is kind of outside their normal response area, they will then task a local search and rescue team to respond instead. The call goes to a search manager who then determines the resources required for their team and activates their team. North Shore Search and Rescue itself has been around since 1965. We are the busiest search and rescue team in the province. Squamish is a close second and catching us, but I think we're still a little bit ahead. We have about 40 active members, and so an active member is a member that's fully trained and will respond to calls in the field. We also are supported by about 30 resource members. Some of these will respond into the field, like a dog handler or a drone operator. Others kind of just support us behind the scenes, and we need a lot of that. So we have an accountant, we have a pharmacist that help support our program but don't actually go on calls. If you look at the minimum medical training that's required to be in search and rescue in BC, it's actually only a 7-hour basic first aid course. Many members of many teams have further training. So in a recent survey, many have an advanced first aid certificate of 16 hours, and we try and maintain this as at least a minimum with North Shore Rescue. About 35% will have a professional level or like an occupational first aid level, and about 13% of the search and rescue volunteers in the province are a licensed practitioner such as paramedic, doctor, or nurse. So obviously a lot of the calls we go to are because of medical or trauma-related issues. There is a lot of just searching as well for lost people or helping people when they're lost, but a large proportion are also due to illness and injury that occurs in the wilderness environment. And so some colleagues and teammates actually started to look at these numbers for North Shore Search and Rescue and published a paper. If you look at 25 years of North Shore Rescue calls, between 1995 to 2020, there were 2,078 calls that our team did. Of those, 41% were classified as medical, and they classified these, this includes like trauma and non-trauma. So about 54% were trauma-related, and about 41% were non-trauma related or more of a medical complication. 3% were body recovery. And then if you look at all of these, about half of them were actually severe enough that they required transport to hospital for further care. So the conclusion of this study was that there's actually a high degree of medical acuity happening in search and rescue in BC, and there's a need for a specialized medical care embedded within search and rescue operations in this environment. Which brings us to the North Shore Rescue Program. So in 2018, we founded a program which was Alec Ritchie was very pivotal in doing, that essentially in response to looking at our calls and saying that there's a huge increase in these medical calls, there's an increase in the complexity and the care needed in the field, and we needed the ability to respond with increased resources. And so they decided to have, from now on, I'll just call it the AMP program, or Advanced Medical Provider Program, which would be comprised of paramedics, nurses, or physicians that could respond in the field to the appropriate calls and provide advanced care. And this was the first of its kind in Canada, as far as I know. So as far as developing that program, the first challenge was trying to figure out who these AMPs are going to be, right? How do you take someone from the hospital environment and put them into a Class D long line helicopter rescue in the winter and expect them to function? You know, this is a picture of my hospital trauma bay. The other day I was working, I was like, I really need a picture of my trauma bay and all the resources. And someone called a code in there, and within 15 seconds, all these people are in there, right? So if I'm working there, I have a nurse to start my IV. I have a nurse that draws up my meds. I have a nurse that administered my meds. I have a nurse that puts the patient on the monitor and actually knows how to use that monitor. I have a respiratory therapist that gets all my airway equipment together and bags the patient. You know, if it's a big trauma, I might stand at the head of the bed and I might not even touch the patient. Sometimes I joke that intubation is like the easiest thing I do because someone else literally does everything. I walk to the head of the bed, I put a tube between the patient's cords, and I walk away. And everyone else does everything else. So obviously that's not the reality when I'm in the end of a line under a helicopter by myself with another search and rescue member. And so how do we get, take physicians out of the hospital and put them in the field and have them be able to function? So we kind of thought about what we needed, who we were looking for. You know, in an ideal search and rescue call, you would have a interprofessional team. So you would have a physician, a nurse, and a paramedic on every call. This is not a reality. We don't have those resources. We don't have the space in the helicopter. We're lucky if we get one of those. So we needed someone that could kind of bounce back and forth and have some skills from all of those professions to bring to a call for a response. Also, some core skills, obviously clinical excellence. If you're not good at doing it in the hospital, you probably shouldn't try and do it on the side of a mountain. These people needed to have some basic mountain skills because the biggest thing is they needed to not be a liability. And if we started a program and we put these people into the field and they were a liability, it would get shut down right away by our team, right? Some willingness to be involved in some search and rescue training for those purposes. Teamwork, communication skills, obviously huge in this environment. Ideally, they'd have some pre-hospital training. And then most importantly, they'd be adaptable. They would understand that the medical care of the patient is not always the number one priority in a search and rescue environment, and that they were not necessarily the boss of everything. So luckily in the Sea to Sky region, we have a great training area for physicians. Whistler Blackcomb, people ski really fast. They drink beer at lunch. And then they wreck themselves. There's also lots of old people that go skiing that have lots of medical problems. And so we got a huge pool of our initial AMPs from on-hill ski hill physicians with patrol, just because there is an ability to get like consistent pre-hospital experience with patient assessment management and packaging in the field in a kind of a bit more controlled environment than search and rescue. Obviously, paramedics would be more easily adaptive to search and rescue, but in BC, there's been some challenges getting paramedics able to practice their full scope of practice in the field. This is changing, and hopefully we'll get more and more paramedics involved in search and rescue because of that. But at the time that we started our program, most of the candidates we had that were interested in working with us were physicians. So once we had our pool of people that we thought we could adapt to be search and rescue AMPs, we needed to develop a set of criteria with our search managers. So our search managers are mostly not medical. So we needed some basic criteria that they could kind of understand in order to decide when we should deploy an AMP on a call. And as we all know, the information you get pre-hospital, you only get half of the information, and half of the information you get is wrong. So this is the best, to the best of our abilities, if we think one of these things is occurring, that they should then activate our AMP team to be part of our search and rescue response. And so, abnormal LOC, with medical illness, anything that's involving chest pain or shortness of breath. We said anything that sounds like a complication of diabetes, significant hypo or hyperthermia, and then extremes of age. So anytime we had a pediatric or an elderly patient, we wanted to potentially be involved in that call. Trauma is pretty self-explanatory, trauma with big mechanism, where they seem unwell. And then the other things that we've really encouraged them is if it seems like there's a need for analgesia, so significant limb fractures or dislocations that might require procedural sedation for splinting, and extraction or a reduction, that we should be called. So if we look at the first 5 years of our program, and some of the same colleagues that did the first paper did this one to see how we were doing. We looked at all our calls from January 1st, 2018, so that's when our program started, till December 31st, 2022, and there were 767 call-outs during that time. Of those, 293 were determined to be medical, and of those, 99 were determined to be AMP calls. So the simple ankle sprains or wrist fracture, things that could be easily dealt with first aid, a splint and extraction, the AMPs do not go on. They're going on those more significant calls. And when we looked at all the AMP calls, obviously there were sicker patients. Often there was a helicopter used because there is an urgency for extraction, so we're doing more helicopter rescue, more Class D or long line rescue, or hoist rescues, and then a lot of mutual aid calls. So the interesting thing about North Shore Search and Rescue is we are the only team in the province that can fly with night vision. So we can fly at night and land in a mountain environment or a non-lit runway or helipad. We can also do a night vision hoist rescue. And so because of that, we get quite a few mutual aid calls from other teams in the province when they have an urgent need for extraction overnight. And these are often medical, right? They're often trauma or a medical issue that's caused the urgency of the extraction. And so, and many of these calls, an AMP is involved to go and help that neighboring team to extract a patient at night to definitive care. So as far as what we've been seeing, what we're doing, lots of trauma, polytrauma being the most common, bad lower limb extremity fractures being quite common as well. Obviously, those are more often in need of analgesia or procedural sedation compared to a upper limb that's more easily splinted. So the AMPs get called for that. Also, traumatic arrest, spine trauma, head trauma, etc. As far as medical things, most often we're getting tasked for cardiovascular complaints because obviously there's a concern that it's something serious if that's the system involved. Lots of exposure, so hyperthermia or heat illness in the summer, and then concerns for hypothermia in the winter, and some mental health as well. As far as what medications we're using regularly, so we track all this. These obviously reflect the nature of calls we're going on, lots and lots of analgesia in a variety of forms. So we can use IV, intranasal, IM, or PO. We have methoxyflurane, which is nice in our environment, especially if it's quite extreme terrain or we're very time compressed. And then a little bit of cardiac medications reflecting the cardiac calls that we respond to. For procedures, most common procedures that our AMPs are involved in is simple splinting and spinal immobilization. This reflects the austere environment and the nature of injuries we see and the fact that often it's not reasonable to do a lot in the field. But we have the ability to and have successfully done advanced airways, advanced trauma procedures, as well as advanced diagnostics like EKGs in the field, which help determine destinations of these patients. My personal opinion is this is kind of our most important thing we do, is that we help with advanced decision making. So having someone with advanced clinical skills and assessment skills on scene really helps the team as far as deciding how you're going to treat this patient and what they need. So we can help determine whether this patient needs to go in what we call an aerial rescue platform, which is a stretcher with a vacuum mattress in it for a helicopter rescue, or a full stretcher carry by the team, versus it's safe to put them in what we call a screamer suit, which is like a big diaper harness for when we're doing long line rescue. The name is, some people find it a little bit exciting. And so if we put them in the screamer suit, our rescue is a lot more simpler. And so if we can say, hey, yeah, no, we don't need to worry about C-spine, we can do that. It's quite helpful. We often help determine receiving hospital. So if we do an EKG and see an ST elevation MI, they can then be diverted to a cath lab center, or if we think that there's a chance that this patient's going to need ECMO. The other thing that's really important that we do, which I think really helps with the physical and psychological safety of our team, is confirmation of death. We're obviously comfortable doing that. It takes the weight off our team. It also takes a emergent rescue operation and turns it into a routine body recovery, which is very helpful for maintaining rescuer safety. So in the last year, just for some updated stats, North Shore Rescue had 142 calls. We had 28 AMP calls, so 20% of our calls were AMP calls. And I think this is increasing over the year, and this reflects the fact that our team has really gotten on board with this program. They really value the program. Our search and rescue search managers are now much more likely to call us and ask for our help. Even if it's like, hey, I don't know if this is an AMP call. Do you mind talking to the subject on the phone and determining that? Or can I tell you the details and we'll decide whether we're not going to send an AMP? We also sometimes send two now. We've identified that on serious calls, it's great to have two of us. So yeah, it's being used more and more, and it's really well received by the team at this point. So we're going to more calls. Of these calls, 20 went to hospital, 17 were handed to BC EHS for transport to hospital, 3 were direct to Vancouver General Hospital helipad, and we had 3 deaths. As I mentioned, we have developed a protocol, thanks to Alec again, where we can do a direct to Vancouver General Hospital helipad transfer for patients that meet criteria for a life or limb threatening injury or illness. So this was our first one, avalanche victim on Mount Kane, which had a severe limb threatening fractures with vascular injury, flown direct to VGH. As far as how our program's grown and where are we now, we have 13 AMPs on our team. These are currently 12 emergency physician and anesthesiologists and 1 emergency medicine nurse. 3 3 of our AMP members are also full search and rescue team members, as well as air rescue technicians like myself. We've also trained 4 additional AMPs to do like a simple single up hoist rescue so that we can minimize patient care disruptions in these rescues. And then, as I mentioned, we have a direct to VGH helipad transfer protocol. We have a patient record keeping system where we can keep track of all our stats, procedures done, medications used, destination of patients, so that we can look at our statistics over time and learn from them. We have a quality assurance program where quarterly we review all the cases that have happened to see if there's any learning points or anything we should change or learn from them. We also provide lots of medical skills and scenario-based training for our team to just enhance the team's overall ability to care for patients in the field, especially if for some reason one of us is not available. As far as next steps, my question going forward is kind of how can we use our resources and experience to enhance patient care in search and rescue or elsewhere in the province. So, you know, we are based in a large urban center. We have a lot of resources. We're super lucky that way. Do we use our resources and do mutual aid and go to these places ourselves, or do we support these other teams to develop their own programs within their own communities? And I think the answer is probably a combination of a bit of both. You know, we have more resources, we're lucky that way, so we should use them and disperse them as needed when asked. But also I'd really like to see us support other teams to develop AMP programs, or if there is a lone physician on a team somewhere, supporting them to feel supported so that they can develop a program or provide this level of care without feeling isolated.